All right, can you see my screen?
Yes, that's good.
Very good. Okay, so welcome everybody to sort of the next section or lecture on advanced cardiac. This is one that I've given a couple years ago, and I think it continues to prove very, very important in terms of a skill that I think people need to start using other than the usual LV function and that sort of thing. So the objectives are to sort of show you and teach you how to use an integrative approach to assess valve function and to introduce you to how to study color flow and to assess color flow through the main valves that we are looking at, and that's the mitral valve, aortic valve, and tricuspid valve. Now this is can be challenging, and so I suggest that you guys practice on every single cardiac POCUS that you guys do, rather even if you don't suspect anything. As emergency doctors, we are really only there to identify and quantify and identify the major lesions. So if someone has a trivial mitral regurg, we don't really care about that. And so the three main valvulopathies that we're going to be talking about today are mitral regurg, aortic regurg, and tricuspid regurg. So I love it when there's a recent case of a lecture that you're about to give, because it just reinforces how important some of the things that you want to, or the information you want to bring to your learners is. So this is a case that literally occurred last week on January 4th. This was a young woman, 26-year-old female that came in with some palpitations, some chest pain, and some shortness of breath on exertion for the last few days. And the bedside echo done by the eMERGE doc and the eMERGE resident showed that there was a little bit of a pericardial effusion there. And so I'm sure we all have seen this many, many times. The diagnosis was initially thought to be pericarditis. And I'm sure almost everybody here would say, well, usually we would send these patients home on NSAIDs and some colchicine and arrange a follow-up with cardiology. But because of the pandemic and maybe the fear of having a difficult follow-up, the eMERGE resident or the doctor decided to ask cardiology to quickly come and see this patient and give them their opinion. So the cardiologist actually came down and used our machine to do an echo on this patient and saw something there that was a little bit concerning that may not have been picked up by the eMERGE resident. And then they put color flow on it and saw this massive aortic regurg on this young woman, identifying this as a vegetation. She was diagnosed with endocarditis, eventually was found to have brain emboli, and the next day or 2 days later underwent an emergency valve replacement. So I don't want to tell you that this is going to happen every single time, but there is no question that if you don't look for it, you'll miss it. And so I think it really is important that to realize that you will miss some critical diagnoses if you don't actually assess your valves. So when you want to look at them, you want to look at them sort of in a simplified approach. First, by doing a 2D or B mode evaluation. That's the same thing as what you're doing in all your other images. And you want to look for 4 different things on your valves. You want to look at coaptation, excursion, any masses, or are there any secondary signs of valvulopathy? So what coaptation means is you want to look at how do your leaflets close. Obviously, you're supposed to see that they close nice and properly and symmetrically. And here we can already see that there's something going on in this mitral valve that is not really closing normally. And if I zoom in on that video clip, you can clearly see here that the posterior mitral valve looks like it's bowing posteriorly into the atrium. And sure enough, when the patient went for an echo, that was found to have severe mitral prolapse because of a posterior leaflet that is bowing back into the left atrium. So this was the first indication. The second thing you want to look at is how are the valves opening? They obviously should be opening up very wide and very easily. And you can clearly see here that the anterior leaflet here of the mitral valve is opening and kind of fluttering a little bit, but not open very much. And here is a case of a rheumatic mitral valve where it sort of opens in terms of a hockey stick appearance. And again, giving you that indication that there might be something going on with the valve function. Similar to the case I just gave you, The first indication of something going on where there was some sort of mass or something going on the valve that is not normal. So if you see some sort of mass or calcification, again, it's an indication that there is something abnormal with the valve function, and that should be interrogated a little bit more further. And then finally, patients who have valve problems from a chronic nature, they usually will have secondary signs of fluid overload. So this patient here who has got a massive left atrium, is this left atrium huge because of severe diastolic dysfunction, or is it because this patient has severe mitral regurg, or both, but you don't know? But this is clearly something that needs to be interrogated further. And then this patient here who has severe LV dysfunction, again, suggests that maybe there's some chronic fluid overload, and maybe that needs to be assessed. But the real sort of art of assessing the function of the valve really goes when you assess for color flow. So if you want to look at, this is the anatomy of every single regurgitant jet that you will see. It has three components. The initial component is the flow convergence area, and that's the area just in front of the valve, which is where the velocities of the blood are starting to increase. And just in the same way that when you unplug a bathtub and you see that whirling water right near the drain, that's giving you an indication that there is a regurgitation there. And the flow convergence is a very important measure of the severity of the regurgitation. So the bigger the convergence area, the larger the regurgitation is. Unfortunately, it is quite technical to measure, and if these people are tachycardic, it's a little bit challenging. So I wouldn't really advise you to use that as your measure to identify the severity of the valvulopathy. The next area is the vena contracta, and that's the area of the most rapid velocity of blood, and that's the blood that's coming through the mitral valve or through any valve, going backwards into the chamber. Again, very, very challenging to measure. So again, I wouldn't use that. But what I would use is the actual jet, and that is what we'll be focusing on during this talk. So here's an example of a mitral regurgitation jet that shows all three components that I just talked about. So in the front there is your flow convergence zone that you can clearly see is quite big. Your vena contracta will be, if you want to measure it at some point, will be that area where the valve closes. But the real sort of where the money is for you guys is the regurgitant jet, and that's where you're going to be focusing your eyes on to first determine whether or not there is a severe valvulopathy. And second of all, this is where you're going to be doing your measurements. So how are you going to obtain your color Doppler measurement? And then how are you going to measure the severity of your regurgitation jet? Well, first and foremost, obviously, is you must obtain a good quality parasternal or apical view of the valve. If you can't get a good image, don't even bother to start measuring, because your measurements will be off. So you really have to focus, and I think that's the real take-home point for all of my lectures, is that you really have to have the best quality image that you can have. So once you have your image, you want to turn on your color Doppler and put that box in the area where the valve is. And you want to identify whether or not there is any regurgitation or not. And you'll identify that regurgitation by, you see the timing of whether or not your valve should be open or closed, and also the color of that flow. So remember that flow going towards your Doppler probe will look reddish and white, and then reddish and yellow, and then flow going away from your Doppler for your probe will be blue and bluish white, and we'll see lots of examples of this. Once you've identified that there is actually some regurgitation, you want to freeze your image, and then you want to maybe cine loop back to obtain your best view of your jet, because that's where you're going to be performing your measurements. Couple little key scanning tips. If you're putting your probe on, let's say the mitral valve, and you see that there's this little wisp right here, you can see as a little wisp right there when the valve is closing of a mitral regurg, we don't care about this. There's no point in stopping measuring it and taking time away. This is not a clinically significant problem that we have to deal with in the emerge. So don't care about the mild or trivial pathologies. A couple other scanning tips is you have to realize is when you are placing a colored Doppler box, the computer that's in your ultrasound has to process everything that's inside that box and determine whether there is flow and sort of processing the color flow in that box. So it's important that if you want to look at just the aortic valve, make sure or measure or resize your box so it is just looking at your aortic valve. Similar with your mitral valve and similar with your tricuspid. So don't just put a box over the entire thing, because then your image quality will not be very, very good. So here's an example of a box that is looking at the tricuspid valve, and you can see, as we'll talk about, this is a very impressive tricuspid regurg, but you can see that the box is just around the area of interest, and we're not focusing or putting a box around the other thing. So make sure you learn how to resize your box to correspond with the valve that you're looking at. A couple important things is that almost all symmetrical regurgitations will go basically backwards and centrally through the valve. And what is important to identify is that if you have an eccentric jet, and that's a jet that is flowing sort of eccentrically along the border of the wall of your chamber, these valves are always worse. So the regurgitation will always be worse than what you're seeing on the screen. So just beware of your eccentric jet and look around to see the direction of flow of your regurgitation. So here's an example, we'll look at it again, of a mitral valve. And you can clearly, or you can see here that there's really impressive regurgitation that's eccentrically along the anterior border of the left atrium. And so that's important to know. And here's another example of an aortic valve regurgitation that is eccentric. And you can see how the jet is coming down and pushing against the mitral valve and not going backwards centrally like you normally would. So if you see this is a jet that's going like this is a much more severe regurgitation than what you might actually see when you measure it. So just be aware of those direction of flow. Okay, so let's go through the 3 different valves and how to measure the severity of each of these valves. And we're going to start off with the mitral valve, which is the most common one you guys are going to look at and see. And how do you identify and quantify your mitral regurgitation? So for mitral regurgitation, you want to compare the area of the jet with the area of the left atrium. All right, and so here's a box that gives you an idea of how to measure and get a clinical idea of how severe the regurgitation is. So if your total jet area is less than 20% of the left atrium area, then you consider that to be relatively a mild regurg. If it's between 20 and 40% of the left atrium, then it's moderate. If it's greater than 40% of the left atrium, then you consider it a very severe jet. And obviously, if you see some big jets that's swirling around the entire left atrium, like we just saw, then that's obviously a severe regurg with eccentric flow. So let's look at a couple examples. Here is an example of a patient that has a very small amount. It's a little bit eccentric, but this is clearly less than 20%. Maybe this is 10 to 15% of the entire left atrium right here. So right away, you can say this is a pretty mild regurg. I'm not really worried about this being a clinically important regurg based on the reason why this patient is coming in. Here's another example of a regurgitant jet. Remember, you look at the flow going backwards into the left atrium when the valve is closing. And this is for sure going to be just under 40% or 50%, maybe half of the left atrium, and certainly more than 20. So if you look, this is clearly a moderate regurgitation that you have to then go and see if the patient has been known for this. Is this a new finding? But again, this is something that you have to take some clinically important decisions on. And here's an example of a moderate or maybe severe jet of this is an apical 4-chamber view. So you can see that when the valve closes, that this jet already goes down. You can see at the same time, it's going away from the probe. It's blue and white and swirling around at the same time, coming up as being red. So this is a moderate severe mitral regurg. And this is, again, something that you have to find out if the patient is known for this or if this is a new finding. And this is another very severe regurgitation. Here is an example of that eccentric jet going down the back wall of the atrium and going up in the same way. So this is a really impressive regurgitation. And obviously, if somebody is symptomatic, you need to get cardiology involved right away for this. So Mitral is all about comparing the area of the jet with the area of the left atrium. We move on to the aorta and the aortic regurg. This is where we now want to compare the width of the jet with the width of the ventricular outflow, which is where you're going to actually see the aortic valve regurg. And so that's where you're going to need to use some, you're going to have to freeze and cine loop back to measure your width of your regurgitant jet. So if your regurgitant jet is less than a quarter of the width of the LVOT, then it's considered to be a mild regurgitation. If it's anywhere between a quarter and maybe 2/3, it's considered moderate. And if it's more than 2/3, then you consider that severe regurgitation. So let's look at a couple examples. So here's an example that we saw already when we talked about the moderate mitral valve. But here we already saw there was some wisp, that little wisp right here, that is coming back when the aortic valve is closing. Now you can clearly see that this is here about 15, but less than a quarter of the width of the entire LVOT, and that's the LVOT here. So this is a patient with mild aortic regurg, and we could have figured that out just by eyeballing it, but this is how you would measure a regurgitant jet from the aortic valve. Here's an example of a patient that has moderate, maybe even severe regurgitation. So if you looked at them, if you measured the width of the left ventricular outflow, so it's from here to here, the width from here to here is clearly 2/3 and maybe even more. So this is a patient that has moderate to even severe aortic regurg. And again, this is important to go find out if this patient is known for regurgitation of the aortic valve, or if this is a new finding which has to be looked at and examined with cardiology. And then finally, here's an example of another severe aortic regurg. This is an apical 5-chamber view. So left atrium, left ventricle, right ventricle. Here's your aortic valve and your aortic outflow tract right here. And if we just go and again, you can almost eyeball it to see that there's a large regurgitant jet coming out of the LVOT during diastole. And so this, again, find out whether this is important or not. But as I mentioned, a lot of this can be done just by eyeballing it. You can see that this is a patient that has a kind of a prolonged regurgitation jet right here during diastole. And we can probably say that this is a mild to moderate regurg just by eyeballing how it looks. And you don't have to necessarily spend the time to measure the LVOT width and the regurgitation width. Okay, the third valve, and that's a tricuspid valve. So remember, mitral valve, you're looking at the area and you're measuring the ratio of the area of the jet with the area of the left atrium. The aortic valve, we're comparing the ratio of the width of the jet with the width of the LVOT. And for the tricuspid valve here, it's the overall area of the TR jet. So this is something you're going to have to find out on your machine, whether or not your machine can actually trace a path around a structure and provide an area based on that tracing. So as an example, if we trace the aortic regurg and it's about less than 5 centimeters squared, this is considered a mild regurgitation. If it's between 5 and 10 centimeters squared, it's considered moderate. And anything greater than 10 centimeters squared is considered a severe regurgitation. Now, I just want to come back and just remind you of my talk a couple of weeks ago on pulmonary hypertension and right-sided failure, where I talked about the speed of the tricuspid regurg. So this is how these two things differentiate. A severe tricuspid regurg does not necessarily mean this patient has pulmonary hypertension. And the opposite is the same thing. If somebody could have a very severe pulmonary hypertension from a very fast tricuspid regurg, but the actual jet area is very small. So they do not go along together. One talks about the severity of the regurgitation. The other one talks about the pressure of the ventricle. So make sure that you don't equate the two. So here's an example of a tricuspid regurg jet that I've frozen, and I see the image. Here's your flow convergence of your tricuspid regurg. Your vena contracta is somewhere in there. And basically, once you have found your best image of your tricuspid regurg, so I'm going to have it, just let it show here and freeze it. Then you take your tracing function on your machine, and you're going to basically trace a line around the regurgitation like that. And hopefully your machine has the ability to measure that. And in this case specifically, this patient has a pretty severe tricuspid regurg. So again, you have to associate this with the patient's symptoms. And again, if you wanted to go further and identify whether or not this person had some right-sided failure or some pulmonary hypertension, you need to do some Doppler, some pulse wave Doppler to identify the speed of that jet going back into the right atrium. So just to summarize, I would say that I think the next step after learning how to do your basic advanced cardiac, and that's assessing your LV function, your RV size, and your pericardial effusion assessment, I think the next thing for you guys is to learn how to incorporate valve assessment and to know how to put your color flow box on your valves and to see whether or not these patients have any regurgitation. And again, if they have minor lesions, and you'll see a lot of them in your everyday practice, don't bother with the minor lesions because they're not important. But you will every so often, just like this case we mentioned from last week. And thank you to Rafi Artunian for giving me this case. You will find cases that will surprise you, and you will miss critical things if you don't look for it. What I would say is eyeball your flow convergence zone. You don't have to measure it, and realize that the larger the flow convergence zone is, the larger or more severe the regurgitation is. And also take a look at the regurgitant jet, just eyeball it. And then if you want to go ahead and measure it, you go ahead. And just remember that the mitral valve regurgitation is a measure of the area, and it's a ratio of areas. The aortic valve is a ratio of the widths, and the tricuspid is just a simple size measurement. So just again, if you see patients like this is a patient that I saw a few years ago. Clearly seeing that there's something wrong with that mitral valve, it's looping back and bowing. And this is a patient who ended up having a very severe mitral regurg. And you will miss some critical findings if you actually don't look for it. And that's it. I will open up for any type of questions that you may have.
Thank you, Joel. No questions in the chat right now. Just to remind everyone, at the end of this month, on the February 3rd, we have a advanced cardiac POCUS at the Sim Center where we'll be going over this material. There may be a very small number of spots available to staff. So if they're interested, you just need to go onto the sign-up sheet, which there is a link for it on the academic rounds schedule. Okay, so
it's actually Audrey. I have a quick question. We have a couple of minutes before our next presentation, which happens to be on a syncope rule. Joel, I wonder if you can just talk a bit about why you didn't talk about stenotic lesions in ultrasound. You have a couple of minutes.
You're muted, Joel.
Okay, so a good question. I have always wanted to give a talk and learn about aortic stenosis because we see it, or we're worried about it very often, and it is a differential for all of our patients who come in with syncope, and I 100% agree with you. The problem is the measurement of aortic stenosis is much more complicated than what we see or the regurg. The regurg, you can take eyeball it, and you can just take a look and see how severe it is. For the aortic stenosis calculations, I don't even know how to, not sure how to pronounce it, but you have to sort of measure the Bernoulli effect pre-valve and post-valve. And I think, yes, eventually, maybe next year, I will give a talk on aortic stenosis because I think it's really, really important. And I just want to, let me see if I have, I don't even think I have here. Hold on, let me see here, share screen. I actually even have, I think on the talk here, No, I don't. Yeah, here you go. I'm just going to share this screen. It's whoops. I'm willing to say now is for aortic stenosis, I want you to look at it. Whoops, can't show it to you. Unskip, here you go. Like I said, it is a much more complicated thing, and we always talk about saying it with an 84 conference. Take a look at the aortic valve. If you see this valve right here that's opening up really wide, don't bother. There's no aortic stenosis of concern, and the patient who may have syncope, it's not because of this. If you're seeing this, where you have a very calcified aortic valve and it's barely opening, then yes, I would actually use that as my trigger to potentially get a formal, or I don't want to say formal, a cardiologist to assess the aortic valve based on your 2D assessment of your aortic valve. So take a look with 2D. If it's open up like that, it's not stenotic. If it's really calcified and barely opening, I would say for sure I would go further with that based on that. But the actual measurement is a little bit more complicated, and I think the real key is for the learners today is to learn how to optimize your image quality and start using Doppler and color as a sort of a natural next step to assess for the mitrals and for the valves and regurgitation. The next step after that would be for stenosis and aortic stenosis, but it's a good question.
Thank you.
Okay, any more questions?